right. So let's go ahead and get started. Good afternoon, everyone. Thank you all so much for joining us today. We're looking forward to a very critical conversation about how we ensure the public health safety measures related to COVID-19 are extended to the field of early education and after-school programs. Thank you so much to Strategies for Children and specifically Amy O'Leary for hosting this event with us, and to all of our panelists that have joined here today. Today, we'll be talking about prioritizing COVID-19 testing and what we mean by that, why we should do it, and how we can do it for the field of early education and care. As many of you know, this conversation comes on the heels of Massachusetts Governor Charlie Baker's announcement that publicly funded weekly screen testing will be made available to K through 12 schools, and that both district and private and parochial schools will be able to use a state contract to access COVID-19 pool testing at a significantly reduced price. As of now, this program is not available to early education or after-school providers. We're gathered today to talk about why a centrally coordinated, publicly supported testing protocol should be made available to the early education and after-school sector, particularly as we look to how we ensure successful access to the vaccine as it becomes available to the field. Most importantly, equity demands that public health measures made available to K through 12 also be applied to early education and after school as well. Many of you on this call are early education and after school providers who've been at work caring for and educating children in person since the earliest days of this pandemic. Your teachers, students, and staff deserve to be as equally protected as those teaching and attending K through 12 schools. Second, we know that testing works. It catches positives before educators enter classrooms, and it allows us to identify and address potential exposures early. It's also brought peace of mind to the hundreds of providers who've been on the front lines these past 10 months. Finally, we know that testing the early education and care sector is possible. While not the subject of today's conversation, our organization, Neighborhood Villages, has been working with providers across Greater Boston and gateway cities to pilot how to do so. In late November, we launched the Boston Children's Relief Initiative, a COVID-19 emergency initiative to support the workforce, testing, and wraparound service needs of after-school and early educators. As part of this initiative, we've implemented a 12-week testing pilot, which brings weekly preventative pool testing to participating organizations, much like what the administration will be providing to K through 12 schools. 7 weeks into this testing pilot, it is very clear to us that while it is hard at times, it can certainly be done. So with that, we are very thrilled to now hand the virtual mic over to our incredible panel. Today, you'll be in the extraordinary hands of Kathleen McNerney, a senior producer editor for WBUR's Edify, who will be moderating our panel. She will be joined by Dr. Simon Johnson of the Sloan School of Management. Simon, you can give us a wave. There, Dr. Johnson, amongst his many activities, was the former chief economist of the IMF and now heads the Global Economic and Management Group and the Global Entrepreneurship Lab. Dr. Johnson is an expert on all things testing and has been advising testing rollouts across the country. We also have Maria Gonzalez Moeller. Maria is the Chief Executive Officer of the Community Group in Lawrence, Massachusetts. The Community Group has both early learning programs as well as K through 8 charter schools. And Maria is an expert on all things related to early education and delivery. Thank you so much for being with us, Maria. We also have Camilla Pontes. Camilla is an early educator with the Epiphany Early Learning Center in Dorchester. We're thrilled Camilla can join us today to provide a firsthand account of what her teaching experience has been like over these past few months since her center has reopened. And with that, I hand it over to you, Kathleen.
Thank you so much. And thank you everyone for joining us. I've been covering the issue of testing pretty closely, especially in the childcare space in the past few months. And I'm excited to talk a little bit more about this issue, especially even as the vaccine is coming. A lot of health experts are saying testing remains one of the core pillars to mitigating the spread of the pandemic. Maria, I'd love to start with you first. You're out in Lawrence. Tell us a little bit about the community group and what it's been like for you all since reopening.
So to give you a little background, we in March, when we were asked to close, when the whole state shut down, we closed the centers, but immediately opened again as an emergency site as soon as we were approved by the state. It was, it's what we do. We had all the essential workers, their children, and all the families that were in crisis. We also took care of their children in the meantime. And that was a great experience for us in terms of learning lessons that really prepared us for reopening. We did reopen as soon as we were able to, and the state gave us the approval. And before we shut down prior to the pandemic, we had about 1,600 children we were caring for, and we reopened, and about 680 of them came back right away. We reopened, and the same fear and anxiety was there, even though we felt confident and prepared from our earlier experience as emergency care center. But our teachers came back. They were anxious, obviously, like all of us. They were working full-time and in person. We supported the closure of our schools during, obviously, in Lawrence throughout this pandemic. But it's really not an option for all our families to stay home with their children. So we knew that it is part of it's our main mission to provide that support for families in our city. In appreciation for all the teachers, returning, coming back, and doing, the amazing work they're doing with the children in person. We actually have, we wanted to do everything we could to recognize and appreciate their work, including staff appreciation pay and as many layers of safety and support as possible so they could feel confident coming back. We are doing it out of our own budget. Most of this out of our own budget, even if it means taking a loss. Thanks to this, I am happy to report that we have very low turnover, if any. A few of the teachers were not able to return because of health issues, but we are grateful for that. I don't want to paint a picture of everything's okay, though. There's still fear and anxiety and frustration and fatigue. But
so what is the cause of that fear and anxiety, frustration? What are driving that? What are you hearing the teachers or families saying?
It's a lot of uncertainty and the numbers in Lawrence are extremely high right now. We have seen a lot of we have seen the cases come into our center. We have detected positive results. At the same time, I am very proud of the way we have been handling it because every time there is a positive case detected, we actually have responded in collaboration with the city and with the Board of Health in a way that is very successful in containing the spread. It always comes from the outside and in, but again, that causes a lot of fear and anxiety, and they always want to know that we're doing as much as possible to protect them, the children, and their own families.
And are you catching cases through health screenings? Is it through somebody going to a testing site, like a state Stop the Spread site? How are you finding out about cases?
We in the city of Lawrence, it is a Stop the Spread site, so we do have accessibility to testing. However, the demand is so high that it does take hours sometimes to make a line to get tested. But again, most of the cases are being detected through testing in the city after being exposed somehow, and then they come in, they report it to us, and obviously we immediately get in communication with the appropriate agencies.
Yeah, and so it sounds like there's a lot that is working really well. At the same time, you've been exploring how to get more weekly surveillance testing, how to bring weekly surveillance testing to your facilities. Why is that something that you want to do?
So the number one reason is safety. there's never enough of that. Health and safety is our number one priority. It always was, but now, it's definitely very visible out there. We want to do everything we can to protect our children, our staff, and their families of our staff and children. We also feel accountable for stopping the spread in our city, in our community. We're very close to our community and collaborate closely with them. And I think, us providing a layer of testing support adds capacity to the public health infrastructure right now where we are. The city has been, and I have to highlight the fact that our city in Lawrence, it has a very strong culture of collaboration and partnership, and the city has been extremely supportive because they understand the importance of early childhood education and childcare in not only for the children, but for the families and for the economy. And they have supported us financially and also through testing. Right now they part some of their testing vans close to our centers so our teachers have better access to it. But again, we do feel responsible for adding capacity. And the last thing, obviously, we want to continue building that support and trust. It is our goal to continue increasing enrollment in our centers. I mean, it's the only way we can survive as a business as well and in the field. For the teacher side, if they are afraid and continue to be so anxious, they are not going to perform their work the best way they can, the high quality of care that our children need, especially at this time. And I think they will be absent more often and we will see more turnover.
So you see both a health and a psychological benefit to having more on-site, continual and quick turn, timely testing. I mean, since Lawrence allowed a testing van to park outside, what difference has that been? I imagine that rather than standing in line for several hours at the Stop the Spread site at Lawrence Memorial Hospital, that it's quicker. Is that the advantage?
It is somewhat quicker. I mean, there is a line that they still have to make, but it's a one-time thing. I should say. But it also what it did is it added a level of safety or peace of mind in terms of coming from the holiday and having access to testing and making sure that everybody gets tested and we can detect any positive cases that are maybe asymptomatic at this point on time. So we can close those classrooms and continue containing the virus was really important. So we did that, and actually it created knowing that we were doing that, we expected less teachers to return after the holiday than we actually had. All of our teachers returned after the holiday and were willing to get tested and continue, working, which was very helpful.
Because they had access to testing to know that they were.
We had already announced to them right, that they were doing it. For families as well. I mean, this testing site specifically is available for families as well. And I have to say, families in increasing enrollment, if they don't trust that we're doing everything we can to protect their children, we're going to have an issue with that they're going to start withdrawing their children from the program or not enrolling them anyways.
Yeah, and we've seen data from the state education of early and care surveys that show that enrollment is much lower. Some of that's because of restrictions on class sizes according to how much square footage, but attendance is also much lower than enrolled. And so some of the things that I've been hearing from some providers is that they feel testing is critical to bringing more families back and therefore helping them stay healthy financially. We've seen some survey data about debt that they're taking on in order to stay open and that sort of thing.
Right.
I'd love to hear a teacher perspective. And Camilla, your organization has been part of this, taking part in the Neighborhood Villages pilot program, which is about halfway through. getting tested weekly. What has that been like for you? And I'm wondering if you can, what is that experience like for you getting tested each week?
For me, it's helped with my anxiety just coming into work every day. Prior to the pooling testing, we had a van that was here bi-weekly at the school, but that was requiring that we stepped out of our classrooms and used our break time to go get tested. And hopefully that testing was also open to the community. So like, we're hoping that like the line isn't long and we're able to get in there quickly. So with this pooling test, we're able to come in from a weekend that everyone's at home doing what they best they can to stay safe. We're coming in on Monday and getting tested in the building prior to children arriving at school. So we're not really taking up much of our time in the classroom. So it's been really helpful. We've caught in some positive cases from it as well. And that's helped us stop the spread where we haven't seen it spread throughout the classroom. It's been cases where there's been 1 or 2 positive tests and we've notified people who were in close contacts. Luckily, we can do pods here. So there isn't much mixing of staff members in that sense. But just really helpful to know that like we are catching it, especially if people are asymptomatic and we're not knowing, or if they're not showing symptoms until later. We're catching it ahead of time and we're just able to alert people who've been in contact with this person, but also families they respect that we have this information to give them and they feel more comfortable as well coming in with their students.
How hard is it? How long does it take to do the test? Is it a swab?
No, we do the spit test, the saliva test there. So it takes about, depending on the person, but it usually no more than 8 minutes or so.
And before, what was the van there since you reopened, or was it before?
No, so we reopened beginning of July. And so at that time, there were no testing here at our center. We were encouraged to go out and get tested at the Stop the Spread locations in the city. Not sure how many of us were actually doing it. I know myself, I didn't actually get tested for the first time until like mid-July. But we didn't get the van, which was in partnership with Whittier, until I want to say probably end of September, early October. And they were here at our middle school location, which is about a 2-minute walk from our location. They were here bi-weekly. So it wasn't a weekly test, but we were at least able to get majority of our staff tested bi-weekly.
Yeah. And you said it totally changed kind of your anxiety level. Tell me a little bit about what was it like going into work every day when you didn't have testing readily available? How were you feeling? Were you feeling it in your body? What was it like?
My anxiety started just based off of myself, just not knowing if I may be passing it to other people. We do wear masks every day in our center, so that is one step we have been taking, but just not knowing, living with someone who also is going and leaving the house and working, just not knowing if we're bringing it to other people. And that's my biggest fear, is being a person who's spreading this virus, but also just having accountability that there are others, everyone else in the building as well, is taking this precaution and being safe as they can be. So that's really helped with me, just knowing weekly, whenever we get the email about our pooling test and the results, just knowing whether there is a positive test, that we are taking the right steps to prevent that from spreading around the building. Or if there's no test, no positives, it just feels really reassuring that we are doing our best to stay safe.
Yeah. And how long have you been working in childcare?
I have been working in childcare at Epiphany for 3 years now, going on to 3 years. Previously, I worked at Boston Public Schools. So just been in the education system for a while, but.
Yeah. It's such an incredible time to have to go in every day, and knowing, I'm sure that there are so many bright spots and joys that the kids bring, but also just helping usher them through what everybody's feeling of some kind of uncertainty about where it's spreading.
Yeah.
It's sometimes can be hard to be that kind of rock for the kids when there's worries on your own mind.
Yeah, luckily they've transitioned really well from coming out of quarantine. I feel like it's just a safe space for them, and I can get that sense from them. So that definitely helps us get throughout the day and calm our anxieties in some way.
Yeah. No, I really appreciate it. And have there been, has Epiphany needed to close down any classrooms, or have you been able to find cases pretty quickly and isolate whoever needs to be isolated and keep open?
We've had all different scenarios. We've had times where certain classrooms have been closed just out of precaution. Even after the Boston Public Health has told us we didn't need to, we were still closing classrooms just to make sure, testing staff before reopening. And then we've had one time where we closed all the classrooms just because it was a person who had made contact with multiple people in different classrooms. So that's happened once, but majority of the time we're catching it soon where we haven't had to close an entire classroom. And that's either through the testing or through our screenings that we do daily.
Yeah, I really appreciate it. So I feel like Maria and Camilla, you have given us a really good picture and understanding of what it is like day to day on the ground, managing the whole well-being of everyone and how testing can play a role. Simon, I'd love to talk to you a little bit about this investment in testing and why, from the research and the work that you've done, surveillance testing is a key component at this moment, especially as vaccines are being rolled out.
Well, that is a good question, Kathleen, and I'm an economist, so I'm going to talk about the numbers. And it's unfortunate that I personally, I think the case for doing this exists just in terms of equity and in terms of the well-being of the workers, Kathleen, without getting to any numbers. Okay, but let's be honest, the state looks at numbers, but budget people look at numbers. So let's talk about that. I think this is one of the most compelling public investments available to us at the moment, or perhaps even ever, because as Maria and Camilla have eloquently pointed out, when you test people, you're better able to keep the childcare centers operating. You can't keep a child center operating if you have an out of control outbreak. The GPH will shut you down, let alone you won't want to go to work. And so then you have to think about the parents and the parents' time and how much they're able to work and earn money and feed their families. And also, sorry to mention this too, pay taxes. So when you weigh up the costs of running these screening programs, which are not high, against the benefits, which is you can keep the childcare centers open, you can protect all the workers, the parents can go to work. This is an enormous ratio, Kathleen, about 10 to 1, we reckon, in terms of return on your public dollars. In fact, I think that while the programs under discussion this week are actually federally funded, that's an important point to stress, because we have stimulus coming from the December package and what is expected to be a package very soon after President Biden takes office. I think you could actually afford these purely on a state basis because of the return on investment. The state would, if the state paid for screening testing, in our assessment, it would get more than that money back because of the extra taxes that they would levy on parents, because parents are able to work and parents are able to buy things for their families, and you don't have to pay unemployment benefit to people because they can actually go to work. So I think it's completely compelling without the economics, and when you add the economics, it's unbelievable. I mean, there's just nothing like it in the world, and it's a mystery, honestly, why the state of Massachusetts, mystery to me, why the state of Massachusetts has not already come to this realization.
Well, I think one of the things that the Associate Commissioner of Education, Russell Johnston, who for the Department of Elementary and Secondary Education, told my colleague Carrie Young yesterday was, there was a lot to coordinate and sort of get in place. There of the 8,000 licensed childcare providers in Massachusetts, 6,000 have reopened. And a lot are family child cares that are in people's homes. It's a lot to coordinate logistically. And that, can be a challenge. I mean, are you seeing when you're looking at programs, and you did work on nursing home facilities as well as K-12, are you seeing that kind of challenge of having so many different sites where staff is working? How hard is it to get testing out without having them have to take time off, stand in a line for 4 hours, and then wait for the results? Is there a way to do it efficiently?
Well, Kathleen, as you just said, I've worked on testing for nursing homes. I've also worked with senior living, affordable housing. I've worked with K-12 schools. We pressed the state for almost 6 months to introduce the pool testing program that they have now announced this week. And they gave us all kinds of reasons along the way about why they couldn't do it, wouldn't do it, whatever. And now they're doing it. So great, terrific. But I think you're asking the right question, Kathleen, which is now they've conceded the point for K through 12. Is there something that makes testing for childcare more difficult, more demanding, more operationally challenging? And I would say the answer is unequivocally is no. And the reason I know this is because neighborhood villages and other people who are active in this space have built and demonstrated and piloted programs that are as good and as effective in terms of additional protection. There's no panacea, there's no magic bullet, as Maria and Camilla both clearly pointed out, and you've emphasized, but in terms of additional level of protection afforded by programs that exist, Kathleen. These programs exist as put in place by neighborhood villages. These are as good as anything put in place by the best run suburban, it turns out, K through 12 schools that we've worked with, and we worked with all schools, okay? But I'm saying where the best programs in the state in K through 12 are comparable to what neighborhood villages has built. Okay.
Are you talking
so
about
not hypothetical? Yes. Is it a difficult thing to do? Of course, everything's difficult. It's the world of COVID. Everything in our lives is difficult. But is this doable? Yes. Is it harder than K through 12 schools? No.
Even with, I mean, in a K-12 school setting, you could go at drop off, right? We've seen this in Wellesley, Watertown, Salem, that everybody's going to the building anyway if they're in a hybrid setting or it's in the community. So you can go and get tested. At a childcare setting, especially across the state in remote rural areas, you're not seeing that it's that complicated. Explain to me how you get over those complications of especially widespread rural childcare settings.
Well, the main difference, Kathleen, is in K-12, we're trying to, and DESE is supporting, testing every child. In childcare centers, we're attempting to, and this is the responsible, reasonable thing to do right now on the basis of what we know, to test the workers. So you're testing the relatively few adults who are already extremely responsible, caring people, who are very worried about health, who understand that infections spread very quickly among children in some instances, who taught everyone in this country the importance of washing their hands already. You're testing those people as opposed to trying to test an entire school population. Testing children is difficult, and that's a major part of the lift. And of course, that's a major part of the ask from unions in K-12 schools, and I think they were right to ask for it. And it is substantially, or I think will likely be completely provided or made available and paid for by the federal government through the state authorities as a part of this DESE program. And I commend them for this. I think all we want in childcare is support what the kind of program that Neighborhood Villages has already piloted, which is repetitive screening testing for the workers in childcare centers.
Yeah, and Maria, you've been exploring this and trying to look at this for your own organization. What have you been finding? Are there these logistical hurdles, or do you think that it can be done and actually have a great benefit by doing it?
Oh, the main barrier or roadblock, it really is the cost for us. And we're looking to test. We are a very large agency. We're looking to test 150 center-based educators, and that is going to be a significant cost for us. We are in the process of finding the resources to do this. We're moving forward with it, and we're confident that we need to find the resources. And we have a board that obviously that supports this because they know the importance of it and the importance of what we do in the community. But it's not going to be easy on our budget, and it's going to be, again, nothing has been easy on our budgets this year, and this is going to be another hit. But again, I think the benefits of it is going to be higher enrollment. Better teacher attendance, safety. I don't think we can compromise any of those things.
Yeah. And how much have you figured out, how much would it end up costing you?
Well, at worst, again, worst case scenario, and well, obviously we have to be conservative in estimating, if we do something around 6 weeks, it really depends on, right, on your level of negative and positive results. But if we assume that in Lawrence, right, it's very possible at the beginning that we have a high number of positive cases. And if we have in all the pools, we have one positive case, it could sum up to, for a 6-week period of time, it's going to be thousands of dollars a week. But I want to say, if worst case scenario of $50,000 for 6 weeks, which is significant. However, that is extremely conservative, assuming that the positive cases are going to continue coming up, which is not the case actually. As I learned from the program, once somebody tests positive, obviously they're quarantining, but they don't have to test again because obviously they may continue testing positive after that. So it's just the cost will go down the more we test and the more proactive we are about it.
Simon, I see you nodding over there. Is there something you wanted to add?
Look, I think Maria said it very, very well, Kathleen. What we know from repetitive screening testing programs in universities, in K-12 and in neighborhood villages program is very consistent, that once you have the program established and you're doing it every week, there are very few new cases. And remember, these are people who are being very careful with mitigation, definitely at work. I'm sorry, across all of those demographics. But there's some slippage at home. You have dinner with the family. You're not wearing a mask during that, and so there is some transmission in the community. And so every university that discloses data shows you clearly that there are some cases that come onto the campus, and you have to be aware that there will be 1 or 2 positives in any such community every week, but only 1 or 2. And as Maria said, that does affect the cost, but it also means that you can catch those cases and break the chain of transmission. I think this is the key idea, Kathleen, which is if you don't do this kind of testing, the disease will transmit in the community. You might be able to prevent it from transmitting in the workplace if the mitigation measures are very strong, but it will transmit among the family members of the workers, for example. And that's bad because many of them may become vulnerable or in turn pass it on to somebody who's vulnerable. So these programs break the chain of transmission coming in from the community. They keep the workers safe. They add a layer of protection, and they don't cost much money once you have them up and running, as Maria just identified. So how do we get them up and running? Well, as we argued for a long time with the state that they need to do this for K through 12, and they've just conceded that argument completely. But what possible logic, Kathleen, would support the idea that this makes sense economically for K through 12 and not for pre-K, or not for 3-year-olds, or not for 2-year-olds? There's no such logic. In fact, the logic, even within the K-12 setting, the economics, just the economics, are most compelling for K through 5, because when they can't go to school, the parents can't go to work. Oh, that's true even more for little babies, isn't it?
Yeah, I mean, I think one of the arguments that I've heard or seen is how much we know about kids' role in transmission. I mean, arguably childcare's, they already before the pandemic were very used to sanitizing lots and lots of things. And now with mask wearing and additional precautions, added on, what I know you're an economist, not a doctor, not a medical doctor, but what do we know about children's role in transmitting it? Because we know that younger children are not likely to get, are more likely to get a mild case or an asymptomatic case than older children. There's some research that demonstrates that, but I'm wondering if you could tell us what we know right now and don't know about the role of children in transmission.
So what has been established, and as you said, Kathleen, it comes with exactly the kind of caveats that you just expressed, which is it's all knowledge under development, is that the existing variants, the ones we've experienced so far in the pandemic, have not transmitted in children, particularly younger children, as much as in older children, let's say adolescents and adults. So that's good news, right? Doesn't mean zero transmission. And of course, there can be transmission, there has been transmission in various congregate educational settings between teachers. Okay, so that's important also. There can also be parent to teacher transmission, teacher to parent transmission. There's lots of adult interactions, as you know, take place. But the other point I would emphasize, Kathleen, is that the British are warning, it's a warning, okay, and should be taken carefully. And I'm not trying to panic anyone. Plenty of caveats about we don't know yet, but the British are warning that the so-called UK variant, which is now reported to be definitely in the United States, that this is more likely to transmit among children than the previous variants that were dominant in the United States. How much more, we don't know. Okay, and I think this speaks to the layers of protection, Kathleen. Mitigation is by far the most important thing. Wear a mask, wash your hands, have good ventilation, keep your social distance, never ever eat lunch with people outside your household. That's just me reading the data, okay? Particularly indoors. If you do risky things, if you do things that are likely to make you increase your risk of getting COVID, you're more likely to get COVID. But a layer of protection, exactly as Maria and Camilla said, and you've said, there's a layer of protection added by the testing, which is, it shows us is the mitigation working. It catches those cases that are going to come in from the community. It keeps that system robust in everybody's minds, the workers, the teachers, and the parents. And this is what major universities have been doing since September. This is what K-12 schools are going to be doing this spring. The town of Wellesley has had a program exactly of this nature running since October, with a lot of back and forth information exchange between them and neighborhood villages. Neighborhood villages has built one of the best programs in the country that I think reflects the state of the art and our evolving understanding of what is an effective testing program. And all we're asking, Kathleen, is for the state of Massachusetts to agree that some of the federal dollars that are being made available for testing be provided to Maria, Camilla, and their colleagues through a program of this kind, or a program that's parallel to what they're offering through K through 12. It's not a big or radical ask, Kathleen. The economics are utterly compelling, and I think from a point of social justice, it's sort of unbelievable it hasn't happened already.
You're nodding your head, Maria. What are you seeing as the social justice component of this?
I mean, our city, it's well known that our cities like Lawrence, and again cities that are just low income families, or families, working families, have been struck the hardest, and again, the impact in the city is much more. I think it's some equity issues come up to surface, have come up to surface throughout this pandemic, and just knowing that the need for childcare is higher in our city, so is the need for testing for our teachers so they can be available for those children. Just having a financial challenge, just, to get this testing, it doesn't justify, having to sacrifice the need for it. So, I mean, I hope I'm explaining myself well on this one, but we just feel it's really important for our children to access what they need, or for our families to access what they need, in terms of childcare, which really will take our teachers to be there, present, providing the care for them.
I mean, it is a reminder of the toll of the pandemic, and that it has been unequal. It's not only higher rates, but higher death rates, particularly in Black and Latinx communities. I don't know if you want to share what you've kind of observed and what you've known in your own community, and what that's been like experiencing this.
Well, again, I did talk about Lawrence. We work very well together, and we have a highly collaborative organization. But we have seen the impact of this on our family, because again, the first thing to go is it's really your ability to go out, your job, your ability to buy food and to sustain your family. And we have seen a huge impact on the families in the city. I have seen unequal access to resources as well. And again, just the fact that there's such high levels of COVID in the city, it's really, it also reflects the fact that people needs to get out of the house to, people will tend to say like, oh, they're just not following protocols. No, they're going to work. They're being exposed in some other ways because they need to survive and they need to maintain their families and to support their families. And I feel like it's our responsibility to support those families that need to do that as well. And again, adding a layer of protection in order for this to happen, it's really not that. It's an easy thing to do.
Camilla, you're going into work every day. You mentioned your husband is as well. I'm wondering what thoughts you have about living in this pandemic and still going into work and seeing, high rates in certain parts of Boston.
It makes me just wonder about like why there hasn't been more consideration about EEC and us working and not getting these testings for the staff members. Just being here since July and just after a while, you start getting comfortable with the people you're around and you're trusting them, but we definitely don't know what is going around like we said, the spread coming from the community. So just seeing the numbers rising and not really seeing the light at the end of the tunnel does kind of bring some worry coming in every day. But for me, just knowing that what I'm doing and what we're doing for the children, it's what gets me up every morning and getting me into the building. But it's hard. It's a hard thing.
Yeah, it is.
Yeah.
And do you, especially coming from Boston Public Schools to before, are you looking at the K-12 space and seeing, do you see, what do you see when you look at those differences between the public schools resources versus what you're able to get as an early educator?
I definitely see that they're getting more prioritized in this sense, and where we're kind of being left off, but still being told that we are necessary to be open for people to go to work, for families to do what they have to do to make a living. And just knowing that our work is so much more hands-on and it's really hard to go a day without touching a child or having to like move around the classroom and be close with our the other staff. In public school, a lot of the classrooms only have one adult in the classroom, so that like also prevents that mixing of staff where we have to have multiple due to ratio, we have to have multiple staff in the classroom. So I just see that difference in that sense and just wonder why we haven't been considered essential workers being back into work and early on in the pandemic. So that's just been something I've been looking into and just wondering about. Also having knowing people who work in BPS currently and the information they're receiving that we don't receive or that we're not being thought of and when they're having these conversations.
Maria, did you have any thoughts on that?
No, I think it's important for the district to work in partnership and collaboration with the early childhood education providers. I understand that at the district level they don't have the same ratio requirements or some of the issues, some of the things that we can do at early childhood education as a safety precaution in terms of ratios and other things, at least prior to the pandemic. But I think, I agree with a lot of what Camilla said. It's when districts closed, providers stepped up to provide remote learning support for those students, and safe spaces for those students to learn, and have very tight collaborations with some of the districts are having very tight collaborations with community providers to make sure that those children are learning and have a safe space to be in. And I just, I don't think that one can be looked at without looking at the other. Again, the same funding that goes to one, definitely, you just can't forget. It doesn't make a lot of sense that a kindergartner, to quote Simon, a kindergarten is getting these benefits, but a pre-K person, a child is not getting it.
Right. Or in your, yes, Simon.
Yeah, I saw a question come through the chat, I think, Kathleen, about whether somehow the state's hands are tied by the federal dollars and the way the federal money has been assigned. And it is true, there are some federal programs specifically for K through 12, but there are also some federal programs specifically for childcare, and there are some federal programs specifically for testing. So, exactly how which bucket they're taking what money from, the state is not made clear yet. But my point would be, there's plenty of money available now from the federal level to support education, including early education. And I spend plenty of time in Washington talking to people on Capitol Hill, for example, and I have never heard anybody say, oh, well, we should give this money to K through 5, but don't let it leak out to childcare. No, that would be crazy, right? Because clearly, Marie and I are agreeing that anything that makes sense for kindergarten makes sense for pre-kindergarten and younger. So the state's hands are not tied at this point, I would say, by the federal strings, Kathleen. The money comes, the way public health and these kinds of educational programs operate in the US, the feds provide the money, but the authority to structure programs and to say, yes, this is an appropriate way to use the money, often, and in this case specifically, is in the hands of state education officials, state public health officials, and ultimately the governor. So I think all we're asking is that childcare, very well-defined sector, be able to access the same resources and the same structure of support and program around testing as schools. That's it.
Yeah, I'm seeing a question in the chat. It's by Anonymous. How do we make sure centers are not deciding between faculty or testing? After the 6 weeks of state funding, the pool testing is $15 per person. A childcare setting with 100 children is $1,500 plus PCR testing for positive cases would be $2,000 a week, or close to $100,000 a year. In other words, that is the salary of 3 to 4 teachers or assistants for pods, or the difference between paying teachers a living wage. For many programs, they're deciding between staff or testing. How do we avoid that trade-off? I mean, this is a sector that childcare workers are not paid as highly as K to 12 teachers. Many are on public assistance programs, and it's not that the programs operate on really thin margins. So if they're not getting federal or state help, do they have to choose? How are they supposed to manage this financially? Yeah. Simon.
Yeah, first, most important, and this is not coming from me, this is what the clinicians and the infectious disease doctors and the epidemiologists are saying. Nobody is proposing to test children, Kathleen, in childcare. The proposal or the request or what's happening is testing the workers, the adults who are working with the children. So that's very important, and that changes the numbers significantly, as you can see. Personally, what I would do, so typically these programs come, as I said, from the federal government, including specifying this is for testing, and there may be other particular buckets or there may be streams of funding, which we don't know what the next package will look like. But there's usually a fair amount of fungibility. And I would personally give money to Maria and her colleagues, and Camila and her colleagues, and let them figure out how to exactly spend the money. And use the request, I think specifically this week, is to give childcare access to the contracts that the state is negotiating and taking advantage of its buying power, because we're buying for 1 million. They're buying testing for up to 1 million K through 12 kids. So that's a lot of buying power, right? You get the attention of the labs and the testing service providers. So let's get access to the same, and private schools can access those contracts according to DESE. So why can't childcare access the contract, look at the pricing, and yes, and then if Maria decides that she wants that it's better for her and her team and her colleagues and the children and the families to put more money over on some mitigation as opposed to onto some other mitigation, I'm certainly not going to second guess her on that, Kathleen. But you need the programs to exist, and you need the cost to come down, and that comes down with scale. So kudos to Massachusetts to getting us into position where we can make this ask. But this is the ask, and it's a very reasonable ask. But I defer to Maria on how she would want to defend her people.
And if I may also say, thank you, Simon, but I may also say it's not one or the other. I mean, that's not even how we've been thinking about it. We, at a personal level and at an agency level, we immediately knew that in order to bring teachers back, we needed to increase their pay, and we called it appreciation pay. And we actually did that, out of our own budget again. That was the first layer that we added, obviously, along with the classic layers of protections that we had at that moment. But it's not enough. And I think that's the point. We shouldn't have to choose between one or another. They should both be there. And that's what we're really advocating for, not to choose paying our teachers well or testing for their own safety.
Yeah, Simon.
I just happened to notice another question by Anonymous in the Q&A, if I may, Kathleen, before we run out of time. And this person asked a reasonable question, which is, if you're doing pool testing, how does that work in a childcare facility, which doesn't have that many workers? And I would like to emphasize, I would refer everyone to neighborhood villages and to look at the details of their program, which involves deconvolution from the original. So when Camilla gives a saliva sample, that sample is used in a pool test. That's what keeps the cost down. And then if anyone in that pool is positive, the lab using part of the same original sample does an individual test. So the result that comes back to Camilla and to Maria tells them exactly everyone in the pool was fine, or it says the pool was positive and it's these people who triggered the positive. And then you decide on the action, like quarantine. So that's an important question, Kathleen, to have everyone clear in their mind. Even though we're using pool testing, and that's important to keep the cost down, ultimately you need to have an individual clinical diagnostic result, like who are the positive people? And then you can protect them and take care of them and make sure they're not able to, they know not to infect other people.
And my understanding is it's most efficient when when the rates are low. So you would be testing and getting more negative tests. Is that right?
Yeah, as a general proposition, absolutely. And as Maria said, you should always think about when you're beginning a program, should the first round be individual tests? And then we go to pools once we know what the prevalence is. Many schools that have built pilots have done that. In fact, we did that as part of the neighborhood villages original steps, or the pre-pilot did that too. So that's a very sensible first step. And generally you find, because we're talking about a population here, childcare workers, just to emphasize, who are very responsible people, who are very aware of health risks and are trying to be as careful as they can, generally you will find in that population a prevalence that is significantly lower than what is reported in the newspapers to be the prevalence of a geographic area. But by all means, let's check that and verify before moving to the pool phase.
There's a question that I think comes up of cases in childcare are relatively low, right? That kids' hospitalization rate is very, very low. And even in childcare to date, I was just looking at the EEC data that was released yesterday. To date, since they started tracking, there have been 1,700 cases of children in childcare who have tested positive, and about 1,900 childcare workers, staff, that have been in those settings. At the same time, the most recent report on cluster data shows that there were 155 new clusters in December 6th through January 2nd, making up 478 cases. Now, these numbers, though, are relatively low compared to the numbers of kids that are going into care each day and the numbers of workers. I think attendance, I should have looked this up. I think the attendance is around 60,000. I'll have to double check that and get that out. But in many ways, what do we know about the effectiveness of testing in terms of reducing the spread in in a situation that, in a setting that seems like it's doing pretty well, that the mitigation strategies are already effective. So if you only have so much money, why spend it here?
Well, again, Kathleen, you could make exactly the same statement with very similar numbers about K through 5 or K through 8 or K through 12. Because people in many parts of the country, it's a big country and there's a lot of variation, but in places like Massachusetts, the teachers, the school administrators, the people who run childcare have taken on board, or actually led the way, in terms of understanding how to be careful and how to prevent transmission in the building, in the facility, on the campus. So that's the good news, Kathleen. But even in the best run places with the most resources, which would be the major research universities, honestly, we still have transmission every week, if not every day. These repetitive screening testing programs catch positive people. They're not getting infected on campus, typically. They're getting infected in the community. It's not, I mean, the people are trying to be careful, but it's an extremely infectious disease. It's very hard for everyone to keep everyone safe and everyone from being infected. So I'm not casting any blame here. I'm just stating the statistical realities. So we know there's transmission in the community that is going, some of the workers for any enterprise, including educational, are going to become infected. They're going to come to work. And then I think it's the responsibility, and look, I'm not making this up. This is what Camilla said she wanted. This is what Maria says she wants. And this is what we hear from across the sector, that people want to be careful, and they want to be careful about themselves, about their colleagues, and about the children they're taking care of, and of course, the children's families. And you don't know who has vulnerable people in their families around you. We don't know that about each other, and we shouldn't know that about. But preventing transmission and catching those cases, breaking the chains of community transmission is the responsible thing to do. It's a very good question. How much money should you spend on it? I think you should spend as little as possible, subject to having effective screening programs. And that's what we're discussing. That's what the state is putting forward. The state is finally using its buying power to bring those costs down. The state's Department of Public Health is finally giving guidance on what is sensible testing programs. Terrific, wonderful. We should just be commending that. But everything that's available for K-5 or K-12 should be made available to the fullest extent possible. And it is a very full extent, believe me, to every single childcare provider in the state. And I don't care how remote the location. There are ways to provide this, Kathleen, and there are technologies already available and technologies that will become available that can provide effective protection, a layer of effective protection. There's no panacea. Testing does not make you safe, but testing is a layer of mitigation protection that is, to which I feel very strongly everyone in this sector, childcare, is entitled to. And the economics are overwhelmingly compelling, because anyone who wants to reopen the economy needs to open and keep open childcare. Where do teachers' children who takes care of teachers' children? I think that's the childcare workers. Who's taking care of the children of the workers you want to come into this or that private sector enterprise? I think that's the childcare sector, Kathleen. I can't imagine there are many essential workers in this economy, but among the most essential are the people with us today in childcare.
Well, I really appreciate it. I feel like I could talk about this for hours and have many more questions. But I am seeing that we are out of time. I really appreciate your time and spending and talking with us, and your work on this, and Camilla and Maria, your work every day with those families. As we said, essential workers. I will note too that the state Department of Early Education and Care is rolling out a pilot. We're waiting for information about that, funded through philanthropy. So maybe there's a solution now, and we'll have to keep watching and see what that looks like going forward.
Great. Well, I want to echo Kathleen's appreciation of all of our panelists this afternoon. Maria, Camilla, and Simon, thank you not only for joining us, but really for the very important work you do, and for your willingness to speak out about it on behalf of the field and everybody. It's a very important topic, and we really appreciate you taking the time to share. And also a very big thank you to Kathleen for being an excellent moderator and really helping us navigate through the questions and the very important discussion that we needed to have this afternoon. Thank you so much, Kathleen.
Thank you for having me.
So with that, we will say goodbye and hope you all have a wonderful week ahead.